Hi, and welcome. My name is Schafer Boeder. I'm an endocrinologist at UC San Diego, and I'm also part of the faculty at TCOYD, which is always a lot of fun. It's a pleasure to be here, to be able to work with Steve Edelman and Jeremy Pettis and Trish Santos and the other wonderful faculty that we have here. So looking forward to today's talk. It's related to LADA, which is Latent Autoimmune Diabetes in Adulthood. And there's a lot of misconceptions about LADA. And it's also, in some ways, a difficult diagnosis for physicians to make. And so people who have LADA often experience, difficulties with their diagnosis, being misdiagnosed early on. So there's a lot of frustration that comes with that. So we're going to talk all about that today. Let me pull up my slides and we'll get going. Okay. All right. So I titled this talk, Latent Autoimmune Diabetes in Adults, the most common misdiagnosis in diabetes. And again, this is because this diagnosis is often missed or misdiagnosed early on. And I think if you have LADA, or if you know someone who has LADA, that's probably a shared experience. It's not, I'm sure, true universally, but it is quite common. So today, this is an outline of the talk. What is LADA? Kind of get into what is latent autoimmune diabetes in adults. The diabetes diagnosis dilemma, why LADA is often missed or misdiagnosed early on. Some of the tests that can be used to actually help make the diagnosis, and this may be something that if you suspect you have LADA, this may be something you can even bring up with your physicians. Many who actually have LADA will have had these tests before, and you may or may not know the results of these tests. We'll talk about LADA versus sort of classic type 1 diabetes. They're the same but different, and we'll kind of talk about some of the differences. And ultimately, kind of give the answer, is LADA type 1 diabetes? Talk about some of the drawbacks of having LADA in comparison to type 1 diabetes, sort of the classic type 1 diabetes. And we'll also talk about some of the benefits of LADA when compared to classic type 1 diabetes. So first of all, let's talk about classic type 1 diabetes versus type 2 diabetes. So what kind of diabetes do you have? And this is an important question. You certainly should know the answer to this. Although, quite frankly, many adult patients with diabetes cannot answer this question, sometimes because they've never been told, or sometimes because they've been told multiple different answers. So it can be very confusing for both patients and also sometimes for providers. So classic type 1 diabetes, we think of as a disease of patients who are younger. So usually it has an onset at a younger age. And typically it has a very acute, which means sudden onset. And so you're living your life completely normal, feeling good. And then within a couple of days to weeks, you're feeling super sick and wham, it hits you like a ton of bricks. Most of the time, people with type 1 diabetes end up in the hospital because they're so ill by the time they get diagnosed. So that's not uncommon to end up hospitalized with severe hyperglycemia or even diabetic ketoacidosis or DKA. Type 1 diabetes, we think of as having sort of a thin body habitus, so being a thin person, or just being kind of normal, like normal weight. Type 1 diabetes is also characterized by having positive autoimmune antibodies. So these are the antibodies that are associated with the immune response in type 1 diabetes. Type 1 diabetes requires immediate insulin therapy. So once you're diagnosed, you get super sick, you end up in DKA, or you end up in the hospital, you're put on insulin from day one. Full court press insulin therapy, multiple shots a day. And that's just how it is, because really at that point in type 1 diabetes, your body's not making any or hardly any insulin. And in general, type 1 diabetes represents about 10% of the diabetes in the United States. In comparison with type 2 diabetes, we think of as generally occurring in an older population, although quite frankly, type 2 diabetes can occur at any age, just like type 1 diabetes can occur at any age. Type 2 diabetes has more of a smoldering progression, generally over many, many years and decades. The disease is probably happening in this pre-diabetes stage before anyone even notices it. Then it becomes diabetes, sometimes with symptoms, sometimes not. And it just slowly kind of continues over time to kind of get worse. That's type 2 diabetes. It's associated with being overweight or obese. Not everybody, but these are associations, as well as with the metabolic syndromes, things like hyperlipidemia, so lipid issues, a big waist circumference, etc. Type 2 diabetes is generally not immune mediated. So if you check antibodies in people with type 2 diabetes, in most cases they're negative. There's not necessarily an immune component. In fact, it's generally not immune disease. And can be, initially, oftentimes it can be treated with lifestyle changes, diet, exercise. It can be treated with obviously many different pills that we do not have in type 1 diabetes. Sometimes people in type 2 diabetes do eventually need insulin as their beta cells sort of give out over, again, years and decades. But that doesn't mean they have type 1 diabetes. That means they have type 2 diabetes and eventually need some insulin. And that can be the case for sure. Type 2 is about 90% of the diabetes that we have in the United States. So some examples of famous people, just to kind of, this is sort of like a stereotypical picture of what is type 1 diabetes. So Nick Jonas was diagnosed at age 13. He has type 1 diabetes, right? Diagnosed very young, was a sudden onset, wham, has been on insulin ever since. Tom Hanks, on the other hand, has type 2 diabetes, was diagnosed at the age of 56, was put on pills and made lifestyle changes, etc. So those are, some sort of classic pictures of type 1 and type 2 diabetes. So what about LADA? So this person, Elizabeth Perkins, who is an actress who actually starred alongside Tom Hanks in the movie Big, was diagnosed with diabetes at age 44. And it turns out she has LADA, latent autoimmune diabetes in adults. And interestingly, sort of her story in 2 lines was that she experienced these sort of worsening symptoms of fatigue and just feeling run down and weight loss and just feeling crappy for multiple years, actually, leading up to her diagnosis of LADA. So this was going on for a long period of time, sort of slowly getting worse until she was diagnosed, found to have a blood sugar in the 600s. Even after she was diagnosed, she actually hid her diagnosis from people at work and the public for the next year after that. She was an actress in the show Weeds. And because she was afraid of the stigma of having this diagnosis. And she, later sort of came out with this diagnosis and has since been a an advocate for people with diabetes. And kind of looking back at it, has trying to deal with the stigma that can come with it. So this was just an interesting experience. And I think it is one that mirrors frequently people who are diagnosed with LADA later in life, right? It's not something that you get at 5, at 10, at 15, and you got to figure it out early and often. You come to this later in life, so it's a different life stage and a different experience, really. So LADA, but in definition, is a slowly progressive form of type 1 diabetes characterized by adult onset and circulating autoimmune antibodies. So in that sentence, you see that this is a form of type 1 diabetes. So we consider this, for all intent and purposes, certainly in terms of how we treat it clinically, it is type 1 diabetes because it has that autoimmune component. It is very frequently misdiagnosed and initially oftentimes treated as type 2 diabetes. So if you have LADA, again, this may be your exact story, but you're an older person, you're an adult, right? You may have been in your 30s or in your 40s, and you were diagnosed with diabetes. Your doctor says, hey, you have type 2 diabetes, take this metformin, lose some weight, even if you're not overweight, eat better, you must be eating terrible because your blood sugars are high. And then, you come back to the office a month or 3 months later, your blood sugar is just as bad or worse. Doctor thinks you're not taking the medicine. They keep adding more type 2 diabetes medicines, and eventually nothing works. And it can take many, months, sometimes even years, for people to come to the understanding that they actually have LADA and be put on insulin. Occasionally, these people never really formally get that diagnosis, and they're just like a type, they're diagnosed as a type 2 who needs insulin super early on, but really all along this was type 1 diabetes. So this does happen quite frequently. We'll talk more about that misdiagnosis. LADA is also defined by a variable decline in beta cell function. So again, in the classic type 1 diabetes, there's probably there is some loss of beta cell function over time, but at some point it reaches a threshold at which the beta cells just essentially give out and cannot produce enough insulin. And that's the point when wham, type 1 diabetes hits you, you get super sick and you're diagnosed. In LADA, that's not necessarily the case. So it's a much slower progression of beta cell loss that can last for months or in some cases years. So it's a different timeline. And again, the decline is variable. So people can have very different experiences even in LADA. Patients with LADA often require insulin within about 5 years of disease onset. So again, that's very different than the classic type 1 where you require insulin on day 1, right? In LADA, sometimes, again, it can be months, it can be a couple of years out, but you're going to need insulin eventually, and it's generally within those first 5 years. And there is something called the Immunology of Diabetes Society, the IDS, and they have sort of a proposed diagnostic criteria, so a list of things that we can use to diagnose LADA. And to quite frankly, not everybody with LADA fits into this category, but this is sort of the proposal. The age is usually greater than or equal to 30 years old. So most patients with LADA are older than 30. Generally, patients with LADA are positive for at least one autoantibody, and we'll talk more about those autoantibodies that you can test for. And generally, people with LADA do not require insulin within the first 6 months or so of diabetes. Sometimes, of course, if diabetes is diagnosed much later, or the LADA is diagnosed much later, they're going to need insulin. But if you think back and say, hey, when did I first have high blood sugar? When did I first start having symptoms? Maybe you didn't need insulin during that first 6 months, and that would fit in with the LADA criteria. So this is a chart that kind of attempts to compare the classic type 1 diabetes, LADA, and type 2 diabetes. So if we look at the age of onset, we see here, of course, classic type 1 is thought to be generally a younger disease. We used to call this juvenile diabetes. That it's a bad name. It's not true. You can be diagnosed as a baby. You can be diagnosed in your 70s. Any part of your life, you can have type 1 diabetes. But it's generally overall diagnosed in a younger population. LADA, of course, is in adults. Type 2 diabetes, again, there are children who have type 2 diabetes, but it's much more common in adulthood as we age. The progression to insulin dependence in type 1 diabetes is essentially immediate. Once you have the diagnosis, you're going to need insulin. LADA, we have this very latent progression to an insulin dependent state that can be months or years long. And in type 2 diabetes, it's always many years. And in fact, sometimes people with type 2 diabetes never need insulin. Sometimes they do. That doesn't mean, again, that they have type 1. It's just a slowly progressive type 2 diabetes. Now, we'll talk, again, more about the antibodies. Classically, in type 1 diabetes, there are many antibodies present. There can be one type of antibody. There can be two types of antibodies. Sometimes they're not there, but for the most part, there's a strong positive antibody presence. In LADA, antibodies should also be present. In type 2 diabetes, they are typically not present. So this is one way that we can actually kind of differentiate between LADA and type 2 diabetes is by looking at the antibodies. The genetics is an interesting thing. There's also sort of a misunderstanding that type 1 diabetes is a genetic disease. Like it's a genetic disease, it runs in families, or, I think, as Jeremy Pettis says, this is kind of, I think, people's way of explaining that it's not really your fault. But it's not a genetic issue. It's not your fault either. It's an autoimmune process, but it's not really a genetic disease. That doesn't mean there's not some genetic risk. So there are some genetic risk factors for type 1 diabetes that can put you at risk for the disease, although it doesn't mean you're going to necessarily get it. So in type 2 diabetes, interestingly, there's actually a very strong genetic component. So if we look down at the family history, very rarely do we see type 2 diabetes that doesn't run in the family. So almost always someone who has type 2 has someone in the family that has type 2 because there's the very strong genetic component. In type 1 diabetes, usually there's only one person in the family that has it. You're the only one. And that's also the case for LADA. So usually there's no one else in the family that has LADA or type 1 diabetes. Sometimes sometimes siblings have it, or there's even multiple family members. That can be the case, but oftentimes you're the only one in the family. So the LADA genetics is a little interesting in that there is some mixed features that really tends more towards the type 1 genetic setup, but there are some components of the type 2 features that may increase, the risk of things like metabolic syndrome, etc. So, but it's mostly type 1. And then if we look at the weight here, again, LADA and classic type 1 share that, people are generally thin, or at least, generally consistent with the whole population. So you can have type 1 diabetes and be overweight and obese just like everybody else. But being overweight and obese really is strongly tied with type 2 diabetes. So the LADA population, this group really fits with the type 1s, okay? So if the vast majority of these things on this table basically are the same between type 1 diabetes and LADA, then why is the LADA diagnosis missed so often? Why are people so frequently misdiagnosed as type 2 diabetes when they really have LADA? Well, that's really just because of this top line, the age of onset. And endocrinologists, general pediatricians, providers who are taking care of young kids or adolescents are so used to seeing type 1 diabetes that if someone comes in with diabetes, they'll assume it's type 1 until proven otherwise. It's really the reverse in the adult world, where type 2 diabetes is so prevalent, so common, that people just assume it's type 2 diabetes, and sometimes incorrectly. So this LADA diagnosis can be missed in adults just because it's so common to see type 2 diabetes, relatively less common to see new onset type 1 diabetes. I see it frequently as an endocrinologist. A primary care doctor might not see it that much. So unfortunately, this is missed, and it's really an issue in terms of education on the provider side. People need to be aware that this exists and look out for it. So again, talking about diagnosing LADA, how do we do it? Well, once we've diagnosed diabetes, how do we differentiate between LADA and type 2 diabetes? So we go back to these autoantibodies, and this is a list of different antibodies that we can test that are present in type 1 diabetes and that are also present in LADA frequently. So the GAD antibody, GAD65, is probably the most commonly tested and is frequently positive in type 1 diabetes and LADA. The islet cell autoantibody can also be tested. And these other antibodies can also be tested. They're less frequently used probably clinically, but depending on your clinic or the hospital or wherever you go to your lab, they may test different pancreatic or islet cell autoantibodies. So insulinoma-associated protein 2 autoantibody, zinc transporter 8 antibody, and an anti-insulin antibody, so antibodies against your own insulin, can all be associated with LADA. So if you don't know if you have LADA and you're wondering if you do, then getting your antibodies tested might be a good idea. So many people who have LADA might say, yeah, I have positive antibodies. And that's a good way to sort of confirm that you do have this autoimmune diabetes, which is LADA. We know that also the more positive antibodies, so let's say you get multiple ones of these tested and you have multiple that are positive, as well as the titers of those antibodies, which is basically the level of the antibodies when they measure them out. If that's higher, those two things will support your diagnosis of having type 1 diabetes or LADA. So if you have multiple positive pancreatic antibodies, then you're likely to have autoimmune diabetes, which is type 1 diabetes / LADA. All right. How do we kind of think about the development of LADA and type 1 diabetes? So how are they the same? How are they different? And this is essentially a graph that shows how the beta cell mass is affected over time in autoimmune diabetes. So the beta cells are the little cells in the pancreatic islets that are working hard to make insulin. That's their job. They make insulin. And unfortunately, in type 1 diabetes and LADA, the autoimmune process is killing off the beta cells. So we talked about this genetic predisposition to type 1 diabetes, which is there, it's present, we can test for it. In the general population, it's not something that we usually test for in the clinic, but we can look for it. We know that there is a genetic predisposition. Not everybody who has certain genetic predisposition will end up getting type 1 diabetes. That's one of the mysteries of this disease to us that people are still studying to try to figure out. Eventually, after some infection or some type of immune response, the autoimmune response occurs, the body starts to essentially attack itself and attack those beta cells, and beta cell injury occurs. And at this point in time, generally we consider people to be antibody positive, because if we test for those autoantibodies against those antigens that we listed on the last slide, we'll find oftentimes that they're positive. Over time, as the beta cells die off, pre-diabetes can occur. That's not a term that we generally use in type 1 diabetes, because again, usually from the clinical standpoint, you're feeling good as a patient, you're feeling good, life's normal, and then wham, you're super sick and you have type 1 diabetes. So this pre-diabetes state is kind of missed. Frequently we see that in type 2 diabetes, since it's a much slower progression. Certainly people with LADA can have pre-diabetes. So that means, hey, your blood sugar is running a little high, your doctor may tell you, hey, you have pre-diabetes, watch your diet, cut back, exercise more, maybe we'll put you on metformin, that sort of thing. But if you have LADA, unfortunately, you can't prevent the next stage. So eventually the beta cells, just like in type 1 diabetes, will continue to die off due to this autoimmune attack. And then clinical diabetes presents when your blood sugars are very, very high, and basically you're not making enough insulin anymore. So in type 1 diabetes, we see that this probably takes some time, but this drop off in beta cell mass is relatively quick, And especially once you get in this phase where the beta cells are really being attacked, then the onset of actual clinical diabetes is very rapid. And just the angle essentially of beta cell loss is much slower in LADA. So it's occurring, it's a similar process, but it's just happening at a slower rate. So let's talk a little bit about sort of the drawbacks of LADA in comparison with sort of the classic type 1 diabetes picture. So it's kind of an interesting way to think about it. So type 1 diabetes, again, it can happen younger in life, more commonly, and it also happens really fast, and it hits you all of a sudden. But what's funny about that is it really forces you to pay attention, because you end up in the hospital, people are there to teach you all about it, and you realize hopefully you realize how important it is to kind of get on board quickly. So it's kind of like ripping off a Band-Aid. Unfortunately, it's like a very painful approach as well, because you don't have any time to settle in. It's just wham, you're sick, right? You're on insulin, multiple shots a day, counting carbs, all this stuff. So it's a lot right up front. But what it does is it gives you that sort of wake up call that this is going to be how it's going to be from here on out. So that's hard with type 1 diabetes, but there's also some benefit to that. Now, LADA, on the other hand, again, first of all, it's frequently misdiagnosed or diagnosed later. So it has this sort of like period of time of uncertainty, and where patients and even providers are like, I don't know what type of diabetes this is. And that could be frustrating in and of itself. But also because of the slower decline in beta cell function that we see in LADA, it can be a little harder to kind of fully engage and commit to your diabetes care. So I know it's kind of a funny sounding thing, but we certainly see anecdotally from my personal experience, many of patients that I have who have type 1 diabetes are very involved, very focused, and that's out of necessity. They have to be. They have to be on top of their insulin to survive and to stay out of the hospital. And I think to contrast that, for example, with type 2 diabetes, that's such a slow onset that you don't really feel it happening. You can kind of feel relatively laissez-faire, and that's what gets people into trouble sometimes, because later on they're going to have complications. So there's something to be said for sort of being forced to take it seriously right up front, and that's what type 1 diabetes traditionally is like. So LADA is kind of somewhere in between, right? So you have this type 1 diabetes, but you're not necessarily getting slammed in the face with it right up front. So that's the bad news, is that it can be a little bit harder to fully engage and to make some lifestyle changes and to buy into the insulin dosing and all of that stuff. At the same time, there can be a little bit more stress about diabetes getting worse in the future, because if you are sort of in your honeymoon period, that honeymoon period can last for months, even years, where you're doing pretty good without having to work as hard at it. Maybe you're doing 1 shot a day and getting away with it, and your blood sugars look okay. But we know that everybody with LADA will eventually need that full basal bolus insulin therapy, just like the classic type 1. So that's going to happen. So it is kind of stressful, even if you're saying, hey, life's okay, I'm dealing with a LADA right now, I'm relatively early in my diagnosis, but I know it's going to get harder. And so just that, specter of the future can be stressful. Again, in type 1 diabetes, unfortunately, the future is now. You have type 1 diabetes, wham. And from there on out, you got to figure it out. Let's talk about the benefits of having LADA versus sort of the classic, rapid onset type 1 diabetes. And this is really important. And I think these points, first of all, they're very true. And I think they're reasons to sort of be happy if you have LADA compared to some of the other, more rapid onset. So if you have any insulin production from the pancreas, that's a good thing. And it makes living with diabetes a little easier. So if you have LADA and you're still sort of making some of your own insulin, enjoy that time. It's important. It's a good thing to have. The reason is because that little bit of insulin, even if it's just a little, is helping to reduce your glycemic variability, your ups and downs, right? So it kind of keeps you from having as bad a high blood sugars. It also actually helps prevent low blood sugars. And so that's really important. It can also allow you to be just a little bit less precise with your insulin dosing, with your counting carbs. Maybe you don't even have to count carbs. Maybe you don't have to correct if your blood sugar goes a little high, because that little bit of insulin that your pancreas is still making can help bring you down. So of course there's a spectrum here, but I think if you still have some endogenous insulin production, in other words, insulin coming from your own pancreas, from your own beta cells, it's a good thing. So enjoy that. Getting diabetes later in life means less years with diabetes, right? So, I mean, you can say, okay, thanks, Captain Obvious. But I think this is actually a really important point, because this can mean that you have a reduced risk of complications, damage to your eyes and your kidneys and nerves and your heart if you have good glycemic control, because you've had less years of exposure to, to high blood sugars and also low blood sugar. So those glycemic fluctuations. So you have, there's a better chance of avoiding any of those problems that we care so much about. We really don't want you to have any of those complications. So if you have LADA, just because you're diagnosed later in life, that's a good thing. And also importantly, better treatments and technologies are coming out all the time. And of course, there's a lot of treatments we're still waiting on in type 1 diabetes. We're certainly waiting on a cure or anything close to a cure. But in the meantime, closed loop systems, CGMs, I mean, these are things that are really kind of changing the game in type 1 diabetes. And, 10 years ago, we didn't have any of this stuff, or at least they weren't nearly as good as they are today. So, if I don't have diabetes, but if I were to get diabetes, I'd rather be diagnosed with LADA today than LADA 10 years ago, because of all the tools that we now have available to use in type 1 diabetes or LADA. So I think that's important. So if we can kind of delay, the need for intensive treatment by even months to a couple of years, then that's a good thing, because, hey, treatments 3 years from now are going to be better than they are today. So this is just kind of an example. This is a CGM download from a patient who has LADA. And just to kind of start off with, if you look at this, so this is basically what we used to call the estimated A1C. It's now the GMI, the glycemic management indicator. But the estimated A1C in this patient was 5.8%, right? That's pretty dang good. Basically, someone who looks like someone who doesn't have diabetes. Average glucose was 120. And they're basically, that doesn't show the time and range, but if you look down here, you can see that their blood sugars are basically within range essentially all the time. They have a couple little highs here, maybe a couple lows now and again. It's unclear if those are real lows or not, but anyway, they're doing great. They're super flat, they're within range. Life is good. So this is the story. This is a 43-year-old female, initially diagnosed with type 2 diabetes, but failed treatment with oral medications. In other words, this person didn't ever have type 2 diabetes. And after about 6 months, was finally diagnosed with LADA and was started on basal insulin. So they started off, hey, 1 shot a day to get going. And 1 year later, which is when the CGM download was from, this patient with LADA was still on once daily Lantus, 1 shot once a day, with an occasional short-acting insulin for correction if there was a high blood sugar. So really, again, this is just one person. Everyone's experience is different. Everyone's timeline is different. But this is it's so much easier to have great blood sugar control with 1 shot a day, to not really worry as much about hyperglycemia and hypoglycemia. And eventually this person is going to need more shots. They're going to need more insulin. That's okay. That's the natural course of the disease. But again, now they have a CGM. They're getting used to that. Maybe in the future they'll use a closed loop pump or an artificial pancreas. So things are getting better from a treatment standpoint. And in the meantime, she's doing great with 1 shot a day. So there really are some benefits to LADA. And I think that's really the takeaway. This is type 1 diabetes. It's a slower progression form of type 1 diabetes. If you have that time that we have sort of a quote unquote honeymoon phase where things are a little bit easier, take advantage of it, enjoy it, but that doesn't mean slack off. Really, it kind of means that's a time to get engaged, learn about diabetes. Obviously, you're doing that. You're here with TCOYD, and prepare for the future where, hey, your blood sugars might be a little bit harder to control, but we're going to have more options. So overall, the future is bright. So some takeaways on LADA. Unfortunately, it is frequently misdiagnosed. I wish I could take an online poll to see, how many people who watch this were misdiagnosed, or at least who had a delayed diagnosis. My guess is it would be pretty high. If you have LADA, you have adult onset type 1 diabetes. You do not have type 2 diabetes, just to clarify. So if anyone asks you, you have type 1 diabetes, and that's important to understand. LADA is a heterogeneous disease. So, people are diagnosed at different ages. There's different numbers of positive autoantibodies. Your titers can be high, or maybe they're not necessarily that high. And the rates of progression to needing full basal bolus insulin therapy are highly variable. That's just how it is. But making any amount of insulin is a good thing. So if you're still making insulin, more power to you. And as someone who has LADA, you have type 1 diabetes, you can certainly benefit from the new treatments and technologies like CGM that are coming out for type 1 diabetes and that are becoming more and more accepted, easier to get a hold of, more options, better features, easier to use. So if you have LADA and you're not using a CGM, for example, talk to your doctor about that. So I think these are important things to really take advantage of when you're managing your type 1 diabetes. So thank you very much. That's all I have. I hope you learned a lot. Thanks for joining TCOYD.